Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Welcome to today's episode of the MenopauseWize podcast on the pelvic floor and menopause. Joining us today is Rama Swami, a well-regarded pelvic health physiotherapist who began her career in India and is now based in Calgary, Canada. After completing her postgraduation from the All India Institute of Physical Medicine and Rehabilitation in India, Rama developed a deep passion for women's health, especially following her own C-section experience. She specializes in treating pelvic floor disorders across all life stages, from puberty to menopause, and is trained in trauma-informed care, sexual medicine, and pessary fitting. A strong advocate for evidence-based care, she actively shares pelvic health insights through public speaking, writing, and social media. So thank you so much for joining us today, Rama, and talking to us about the pelvic floor, so important and dictates so many of our functions. So thank you for joining us today. Let's get started with the basic question. What is the pelvic floor? Where is it? And does everyone have a pelvic floor?
Thank you, Supreet. This is absolutely my honor and pleasure that I'm getting to talk to an audience and speak with such like-minded individuals who share the same drive and passion. So I'm really honored. To answer the question, it is absolutely something that doesn't get talked about much. So everybody has a pelvic floor. All human beings have a pelvic floor. In fact, anyone who has a skeleton has a pelvis. So if you have a pelvis, then you do have pelvic floor. The easiest way that I can explain what the pelvic floor is basically it's a basket of muscles. If we imagine it being like a hammock or a basket of muscles which resides inside of our pelvis, that's the base on which our internal organs sit. So our bladder, the vagina and the uterus, our rectum, all of these internal organs rest on a platform, and that platform is essentially made of muscles. It's an interweaved layer of muscles, and that's the pelvic floor. So everybody has it. Men, women, kids, grandparents, everyone has it.
But why are we talking about so much, we don't hear a lot about men and pelvic floor, but the women and pelvic floor, is there something special about the female pelvic floor?
Essentially, yes, just because of the impact. There's a lot of functional impact that females have with regards to their pelvic floor. So when we think about what are the main functions of the pelvic floor, the basic structure of setting up as a base for the organs, that's common in male and females. But sexual function, reproductive function, it houses and supports our major organs like the bladder, uterus, and the rectum, which during the course of childbirth, during the course of hormonal changes, there is a huge impact on how the pelvic floor behaves. And these fluctuations are more noticeable. They're more significant when it comes to the female anatomy, because in males, there aren't as many hormonal fluctuations. There aren't as many ups and downs that happen. Although with symptoms, males also have symptoms with regards to their pelvic floor anatomy. We just don't tie those two together, and we just don't know that it is a pelvic floor symptom.
Right. So basically for women, there's just so much going on cyclically during different phases of their lives. So the impact is more. Would that be right to say?
That's right.
Yeah.
Yes.
Okay. And what are the signs? You said sometimes the symptoms aren't just picked up. So does a woman come and say, hey, my pelvic floor is not functioning? or what are the symptoms that she will experience to even know that her pelvic floor isn't functioning right?
I wish. I wish that's going to be the day. That would be my hope, expectation. That's my dream, ideal scenario, that someone walks in and says, "Hey, I need help with my pelvic floor." Oh my gosh, that is an ideal world. Unfortunately, we're not there yet. But some symptoms or some signs that point to the area that yes, there might be something wrong with your pelvic floor is when people have the most common irritation, or the most significant symptom that's seen is pain with any sort of pelvic function. It could be painful bladder, so difficulty with urination, hesitancy in urination, or excess urination where it's more urgent, more frequent, trouble managing our bladder function. So either unable to hold it, or unable to empty our pee. So both drastic ends of the scenarios, both of those pose as a function, as a symptom of pelvic floor dysfunction. Going to the next organ after bladder dysfunction, the second organ is our vaginal opening, the uterus. So anything regarding the uterus, when there is a trouble with their periods, if there is hormonal fluctuation, pain with periods, difficulty with periods, or having intercourse, if there is painful intercourse or trouble with intercourse, these again point towards the direction that there's something up with the pelvic floor. When we go to the rectum, our bowel function, our gut, our digestion, having irritable bowels like symptoms. So either constipation or diarrhea. More commonly, people come in with hemorrhoids or fissures, and they have trouble with having a comfortable bowel movement or regular bowel movement. All of these fall under the umbrella of pelvic floor symptoms, and we just don't know that, oh, this is actually pelvic floor.
Right, right. And very often we're just thinking, oh, incontinence, or leakage. When you cough, sneeze, stress urinary incontinence equals pelvic floor dysfunction, or pelvic floor inadequacy, or basically just the pelvic floor is not functioning well, right? But we don't think that, oh, all of these other symptoms could also be because the pelvic floor is not strong enough to hold those different parts of your organ. And I love the way you explained it as a basket holding it. It's so easy to visualize that if that basket is not holding it correctly, then obviously how are those things going to function? It just makes so much sense. And still we don't think about it that often. It's amazing. When is a woman most, you said that women are at more of a risk of pelvic floor problems just because of their hormones, etc. But what would be the phases where they are more prone to pelvic floor dysfunction?
I think the most significant drastic changes that we see is when women go through big hormonal shifts. So we have these milestones in women's lives where there's hormone shifts. So when they attain puberty, going through that change of when your menses start, when your periods begin, that menarche, that is a big hormone shift that happens where estrogen, progesterone, all of these androgenic reproductive hormones are at their peak. So when that starts to ramp up, young girls who are under the age of 18, being 12, 13 years old, even 15, 16-year-olds come to my clinic, and they have trouble with their period symptoms. A lot of it is dismissed as being very common. Arey, hota hai. This is something which happens. Where if they have cramping, if they have painful periods, pain to the point where they're unable to function, then these clue in and tell us that that's not normal pain. We shouldn't be accepting that. And those hormonal shifts are the times when this happens. Another milestone in a woman's life when another big hormone shift happens is if they start to get pregnant and in their reproductive stages. So going through the process of pregnancy and then the roller coaster of pregnancy hormones, postpartum hormones, that's a huge hormonally influenced chemical change that happens, where that basket of muscles, it has to now stretch as the person is more and more pregnant, going through those 9 months of pregnancy. Now that basket is getting stretched. And then when delivery happens, all of a sudden, the weight from that basket is taken away. And how quickly does that basket come back? Does it behave like a trampoline where it comes back and that elasticity is there? Or does the basket stay weak and overstretch? So now instead of your organs sitting up high, they're now sagging down a little bit because your basket is now weaker. So we then check for prolapse. That's a big hormone shift reaction that happens. And as they go through the next phase, which is during perimenopause, menopause, that is the new buzzword because this is another milestone in hormone shift. So when that happens, we see a sharp decline in estrogen. Our body doesn't produce as much estrogen. Progesterone isn't as much in quantity. So these hormonal shifts change the level of elasticity. Our organs, which are sitting in that basket, they are held by certain ligaments. They are held by certain structures, the tone of the muscle. So if our hormones are fluctuating, then sometimes they dip, sometimes it stretches. Other times it recoils back and comes back up. So puberty, pregnancy, postpartum, perimenopause, menopause, these are the big milestones when that hormone shift happens. And that's why it's so significant in women, because in men, they don't go through such a huge roller coaster. It's pretty plateau, it's pretty steady.
Right. But because they are muscles, like the pelvic floor mainly consists of muscles, what do you say?
It has, I would say, I would describe it in 5 structures. Mm-hmm. When you think about it as a basket, I like to imagine it as a fabric basket. If we were to imagine it like a fabric basket, so the main threads, the main fabric of the basket is muscles. Yes, it is built with muscles, but around the muscles, there is another layer. If we think about it in terms of a coating or a layer, it has another sheet, which is the connective tissue or the fascia, which is not as flexible as the muscle. So think of it as a cling wrap layer or a waterproof layer on top of your fabric. That's the fascia. And then the embroidery, the design, the decoration, those are all of the arteries, the veins, the nerves that are there. So these structures make up the fabric of the basket. And then the contents inside, they are held with threads or duct tapes or ligaments, which then make our organs hang inside that basket on which they're resting.
Wow, wonderful. That's a beautiful analogy, and it's so easy to visualize then. So what happens, because most of our audience is looking for help during menopause. What are the symptoms specific to menopause and what really happens at menopause? If you could expand more on that particular phase for women to understand what happens at menopause and to all these tissues because of the hormone shift. And B, what are symptoms to really look out for during this time, specifically during menopause?
Absolutely. So that shift, this hormone shift, it doesn't really wait until menopause happens. The influence of it starts much before. So in that perimenopause transition, so maybe about 7 to 10 years before your periods actually stop, you would start to notice symptoms. When we talk to people about menopause, the first thought that comes to mind is, oh, there's going to be hot flashes, there's going to be night sweats or insomnia. These are the most common symptoms. But from a pelvic floor perspective, one of the first signs or symptoms that you'll notice with hormonal fluctuation or that drop in estrogen is vaginal dryness. The tissue starts to feel different. So when someone's going to the bathroom, when they go to the bathroom to pee, they'll start noticing that it feels slightly zingy. Almost like the start of a UTI, and a lot of people are misdiagnosed with having urinary tract infections because of that burning, because of that slight zingy sensation. They go to their family doctor and they say, I think I have a UTI starting. I'm not sure if it is. And prophylactically, a lot of them are put on antibiotics because it's just, it wouldn't hurt, which is not entirely wrong. But that doesn't correct the imbalance that's happening. So that drop in estrogen brings on burning urination, frequent urination, or changes in that vaginal tissue in the urethra, where people start to feel burning, zinging, just discomfort, even at rest, even when they're sitting, maybe not when they go to the bathroom, not just when they go to the bathroom. So that would be one of the first indicators. The second or another common change that they would notice is sometimes there is a feeling of heaviness, or sometimes there could be a feeling of pressure. This happens when your basket starts to sag a little bit, which is not every single person. This doesn't happen in everyone who goes through menopause, but it's a sizable amount. About 60 to 70% women who will be undergoing menopause notice that heaviness or pressure, which comes and indicates the chances or risks of having a prolapse. So that would be the other symptom. And another fluctuation which happens when we come to our digestive tract, when we come to our rectum or bowel, is changes in the tissue flexibility. So chances of having bleeding when you're constipated, or if you have harder stool, so fissures and bleeding, those sorts of changes starts happening because the tissue gets fragile. Because of that fragility, here in North America, there's a lot of individuals who choose to use toilet paper instead of water for wiping and washing. So that's pretty common. So when we look at the pelvic floor basket, going from front to back, if you start noticing that the sensations are different, the tissue feels different, it might not be time for menopause yet, but these changes begin early on, about 7 to 10 years before that happens.
Wow, that's a lot of time. So
yeah.
The important thing is, yes, if you've already hit menopause, then lots of things that you can do to strengthen your pelvic floor muscle, but also to start looking earlier if you haven't yet hit it, right? Yeah, so that's something to really think about. Now coming to what can one do? In many ways, in the form of pelvic floor exercises. We've all heard of Kegels exercise, but if you could explain Kegels, because not everyone knows what it means, and then explain whether is it enough for us to avoid, let's say, an incontinence or any other symptom that you just described.
Fair enough. And I'm so glad that you asked this question because this is widely popular that do Kegels and your pelvic floor would be strong. But here's my controversial take on it. When we think about Kegels as an exercise, the context of Kegels is the instruction says we're supposed to contract, or we're supposed to squeeze and engage our pelvic muscles and tighten them, essentially just tighten them. And the instruction says, pretend that you're stopping your urine midstream. If you Google the instructions for how to do a proper Kegel, those would be the instructions. But the flip side is about 70% of the people who have pelvic floor dysfunction, they already have muscles that are operating with extra tension. So in that set of population, which is majority of the people, if they end up doing Kegel, they're doing more harm than good. So I'm not against Kegel. Kegel is a fantastic exercise when used correctly, when used with the right population. So in essence, to answer your question about what a Kegel is, Kegel exercises were designed to strengthen the pelvic floor when we had weakness. But not everybody has weakness in the pelvic floor. In fact, it's quite the opposite. Majority of women operate with excess tension in the pelvic floor, and they need to make it more flexible. So rather than strength, we have to look at it in terms of flexibility. The way I explain it in clinic is I move my basket description to a trampoline description. Think about the base like a tight sheet, like a tight rubber sheet. If it is tight and you try jumping on it, you're not going to get a bounce. You're not going to go up and down. And the job of the muscle is to stretch under pressure and then come back when that pressure goes away. So if you have an excessively tight muscle, that's not going to happen. It won't function effectively. Neither will it open and close effectively, because all our openings, our urethra opening, our vaginal opening, our anal opening, all of them have the muscles going around them. So if the muscles are not opening and closing as effectively and you have extra tension, it's going to make life difficult. So the actual way or the actual exercise would not be Kegel. We call it functional training, where it is Kegel and reverse Kegel, because Kegel only talks about squeeze, squeeze, squeeze. You tighten, you tighten, you tighten. Nobody's teaching people to unclench or relax the muscle after that tightening happens. And that is where the nuance of pelvic floor training comes in, because not everybody needs strengthening. In fact, there's a very small population that actually needs true strengthening. I would argue that everyone would benefit from keeping the muscle flexible, because if your muscle is flexible, yes, you can stack up, you can add strength to it, or at least operate at a neutral base. So you're not getting into a problem, you're not getting into dysfunction. At least it's functioning normally with flexibility.
Wow. And how does one distinguish that? Like, is an examination important to figure that out, or one can figure it out on their own? Like, how do I know that my pelvic floor is tight, or is it does it require strengthening? How can I figure that one out?
Absolutely. So it's yes, having an internal examination is the gold standard of figuring that out. And that is why we always insist, when you have to have a pelvic floor evaluation, when you have to have an assessment, it is absolutely valuable to check the tone of the muscle. And the only way we can check the tone of the muscle is if we actually physically try to touch the muscle, if we physically try to see, does it actually stretch when I'm pulling it? And does it actually compress if I let go? Visually, if we just look at the muscle, we can't tell the difference between a tight or a weak pelvic floor, because visually muscles look the same. But it doesn't mean that internal examination is the only way to determine that. That is the gold standard. That is the best way to determine it. But there are ways to find out based off of subjective history. So in an evaluation, when I go through a pelvic health assessment, I book an hour. It is an hour long. It's a 60-minute long assessment where I ask questions. They are very detailed questions about how is the bladder functioning? How is the bowel functioning? How are your periods functioning? What does intercourse feel like? There's intimate questions. There's very detailed questions. Based off of those answers, we can guess, we can have a pretty good idea of whether it is a pelvic floor that behaves when the muscle is tight, or is the pelvic floor behaving in the fashion when the muscles are weak? Because both of these are drastic scenarios. A common example is incontinence. When a lot of people come to me for urinary incontinence, they say, I want to strengthen my pelvic muscles because I'm leaking when I sneeze, when I laugh, or if I have to go to the bathroom, I can't make it in time and I'm leaking pee. So then to that, we have to dig a little bit deeper, because urinary incontinence is a symptom of a weak pelvic floor and of a hypertonic pelvic floor. Both of these situations will give you urine leakage. So then the question becomes, are you leaking when there is pressure, or are you leaking because you're just not able to hold enough? So we get into the nuances of it. So a combination of subjective history, answering questions, knowing their medical history, and if, of course, in the end, a clinical exam, an internal exam would give us that answer.
Wow. So basically, incontinence, either way, it could go either way.
To go either.
Yes. So if let's go to the next step, saying I cannot have a physical exam. Right. I do not have the availability of a pelvic floor therapist. What are the things that I can do to prevent pelvic health problems when I'm younger? And part two is, what can I do which will be okay, like basically which will not work against me? What is it that I can do today to make my pelvic floor healthier?
Absolutely. Yes, there's lots of things that people can do to keep a healthier pelvic floor. The very first one that I would recommend, gold standard, is keep your bladder and bowel happy. So I'll elaborate on that, which means when we feel the urge to pee, when we feel the urge to go, it's good to keep an eye and be aware of how often are we peeing. There is something called an overactive bladder where people pee too frequently. If you're going every 45 minutes, if you're going every hour, that wouldn't be considered normal. On the flip side, in a day, if you only go 2 times, if you're only going 2 or 3 times in the entire day, that's not normal either. So keeping a happy and regular bladder bowel movement means your pelvic floor is happy, meaning which the average gap in between bathroom visits when you're peeing should be anywhere between 2.5 to 3 hours. So every 3 hours, if you're peeing, if you're emptying your bladder, that is the sign of a healthy bladder. On the flip side, with bowel movements, if you're having regular bowel movements, whatever regular means for that individual, that doesn't necessarily mean every day. And this is, again, we can get into details of that. Not going every day does not equal constipation. And just because you're going every day doesn't mean you're not constipated. Because the consistency of your stool is going to determine what it is. So if it's a soft, easy stool to pass and you're doing that regularly, it could be every day, every second day, as long as it's happening regularly, that means your muscles are happy, the mechanism is functioning properly. So regular bladder, regular bowel movements, keeping that as an essential vital sign is a good indicator for healthy pelvic floor. The other thing, and another big thing, is no pain. Absolutely no pain with any of these functions. No pain with peeing, no pain with periods or intercourse, no pain with bowel movements. There should be no pain. If there is any pain with any organ inside of your pelvis, then your pelvic floor isn't functioning properly. The other option is pressure. If there is any pressure with any of the organs, either pressure in the front, either pressure at the back, or pressure internally, which feels heavy, which feels like a weight, then again, that's an indicator that something's probably off.
Right. So basically, keep a healthy bladder, keep a healthy bowel. What else can I do? Now, you mentioned the basket, the pelvic floor muscles, the pelvic floor, other tissues involved as well that constitute the basket. What else determines the health of the pelvic floor, considering it is muscle, it is tissue, it is going to require nurturing in terms of nutrients. So if you could, speak a little bit more about that. Of course, you spoke about constipation, passing regularly, not painful, should be, firm stools. Yeah, not painful. Okay, so that we got. But coming back to what else determines the pelvic floor, because the basket, something's holding it up as well. So does the core strength matter? Do nutrients matter? Like, if it's just not just focusing on exercising the pelvic floor.
That's right.
In any way, right? So if you could tell us all the other things that can impact, so we start working on all the tools that can give us a healthier pelvic floor.
100%. Core strength is a very, very, very important piece. So if we imagine, think about a can. I always say, imagine this whole setup being like a can. The roof is made of our diaphragm, which is underneath our rib cage, the breathing muscle, which is the diaphragm. That is the roof of the can. Your core muscles, your front abdominal muscles, the muscles to the side, the muscles of the spine, which are at the back, that is the body. That is the main length of the can, which makes the body of the can. And the base is your pelvic floor. So if we take this entire unit, strengthening and keeping these units optimal will make sure that your pelvic floor is optimal. And that's where breathing is a very, very, very important part, because that's the roof. If you end up holding your breath, and this is where we also take a little bit of an assessment, little bit of an evaluation about a person's mental health, because all of us, given this day and age, we hold a certain amount of stress. We all operate with a baseline of stress. Sometimes the stress shoots up, sometimes it gets lower, sometimes we're happy, all sorts of emotion, the range of emotions. And based on that, our breath changes. The way we breathe changes. When we're anxious, we're taking shorter, shallower breaths. So our diaphragm doesn't move up and down as easily. When we do that, if the diaphragm's not moving up and down easily, this can now starts behaving like a pressurized can, where the piston, which is the diaphragm, is pressing down. It's adding and pumping pressure. So it's only a matter of time. If you keep behaving and breathing in that way, it's only a matter of time that the floor is going to give out and say, okay, that's it. That's too much pressure on my part. I can't handle this. Second thing to look at is what are the walls? The walls of the can are made of core muscles. So if our core is not functioning properly, if our abdomen, if our deep core muscles, they are not functioning properly, then the pressure is not navigated properly. When we bear down, when we strain, if the core isn't strong, all of the pressure just pops down. It just vertically goes down, adding tremendous amount of stretching, laxity on those ligaments, on that basket that's holding up. So having a strong core, having an aware core where the core is acting efficiently, not acting like washboard. Because when we think about core, a lot of people just tighten their abs and they go, okay, I'm just going to keep a flat abs, flat core, where they suck in their belly or engage their core, turn their core on and say, okay, this is it, great posture, I'm going to keep that right. But that starts to create a constriction. Imagine it being like you're squeezing a toothpaste tube. That's what you're doing to your core. So the pressure is only going to go down. It has no place to go up. Optimal, where yes, you want a strong core, but you don't want a hypertense core. You don't want washboard abs. And then your spine, keeping good spine health, keeping your back muscles as strong as your core muscles, so they share the load. All of this affect how your pelvic floor behaves. So it's very functional. You can't strengthen or you can't work in isolation. The muscles don't work in isolation. Like everything else, it's connected to the rest of your body. So you've got to take care of the rest of it for this to function.
Yeah, and I think that's the important part. And I think menopause has opened my eyes to so many things. So firstly, let me tell you something. When you were talking about core, it's amazing how just you speaking about core, and I suddenly held my tummy tight. It's such a natural reflex. Oh my God, core, I better hold my tummy tight. So it's such a natural reflex for us to just kind of, oh my God, I better hold it straight. So that's one. But the other thing is, I feel like menopause has made me realize that it's so silly, because we had, medical education and all of that. And this should be like natural, right? That the body tissues and cells are talking to each other. But menopause has been like, you're suddenly seeing it in the mirror and saying, oh my God, really? Everything is talking to each other.
Right.
And you just can't isolate things and say, I will look after only the ovary or just the tube or just the this. And we get more and more specialized. Like earlier, it used to be not so common to find physiotherapists. Now you have you specialize in the pelvic floor. But now the pelvic floor is connected to everything else. So we narrow in, but we have to also, again, zoom out from time to time.
Absolutely.
Which is brilliant. Yeah, I'm always so amazed with the human body. It's just so cool. But coming back to the pelvic floor, and you mentioned, we spoke about now the can. I think it's a beautiful analogy to visualize and now kind of work on your breathing, work on your core. All of that is adding value to your pelvic floor.
Right.
What about nutrition?
Nutrition, certainly. Nutrition from two aspects. Adding nutrition as a core component, where we think about not just the food that we're eating, but also the fluids that we drink, because nutrition comes in everything. It is the liquid, it is the solid, it is the micronutrition that comes in, minerals and everything that goes in. So with regards to nutrition, I think the questions that I ask, or the impact of it on pelvic floor, depends on our water intake, because 70% of our body is made of water. And if we lack water, which most of us do, we operate at a sub-minimal level of where we should be with regards to our water intake. When that happens, our body starts to absorb and take away water from all of the tissues, and our mucosal tissues. Mucosal meaning our lining inside the cavity. So the cavity inside our mouth, the cavity inside our vagina, the cavity lining the urethra where urine comes from. All of those are soft mucosal tissues. So with that change in hormone, if our nutrition doesn't have the adequate water content, then yes, you're going to see the effects. We won't call it dehydration, but you would see the effects of dryness. So when you increase your water intake, you will notice a change in the consistency of the urine. It's not as concentrated. If it is more dilute, then yes, the way it interacts with the tube as it's coming out, it will influence how the muscles around it contract or relax. If it is acidic urine, your muscles would want to squeeze really tight because they don't like the acidity. They don't like the zinginess. So keeping your urine dilute at a pale yellow color, which is more like barley water, that is ideal. If it's any darker than that, then you are somewhere affecting how your muscles are going to squeeze. Are they going to block it? Are they going to stop it? Or are they going to be uncomfortable? Which is not something we think about.
Absolutely not. That is so interesting. That is so interesting to know that, okay, yeah, you have to, you're not dehydrated, but you're not optimally hydrated.
You're not optimally hydrated.
Yeah, and the muscles getting that signal that, hey,
Absolutely.
That is... Wow.
And the same thing is true when it comes to with regards to bowel movements. It's more popular. We talk more when we think about water intake. Our first impression is, oh, if I drink enough water, I'm not going to have hard stool. The same analogy, the same mechanism also influences our urology system, our kidneys and our bladder system. So what works well for having smooth, soft bowel movements is also going to help your bladder drain out and flush out the urine in a healthy, adequate way. It'll keep your vaginal mucosa moist. And if vaginal mucosa is moist, then there's going to be less itching. Then there's going to be less burning, because itching, dryness, burning, all of these are indicators that people start to see in and around menopause. So this was all about the fluid intake part of it. When we talk about food nutrition, fiber is a huge, huge, huge factor when it comes to it. All of us are undernourished with regards to our fiber intake. That's a given. It's really hard to have 30 grams of fiber in a day. I can't make it. My average is in 30 grams. I know I can't make it. But then that's when I have to be strict with myself, take a look at what is my fiber intake at, what foods are rich in fiber, how can we get that, because that influences our smoothness of stool. And it's not just the gut microbiome, because when we think about how much fiber we intake, fiber helps the good bacteria in our gut. If the good bacteria in our gut are happy, if they have food, because fiber is their food, all of the good bacteria in our gut rely on fiber. So if we are starving ourselves of fiber, we're starving those bacteria. When we starve those bacteria, that's when we start seeing gut irritation. That's when we start seeing IBS-like symptoms. So if our gut bacteria is healthy, the stool consistency, the stool regularity is maintained. If that is maintained, as our muscles are allowing for that emptying, the release and compression, it makes for a healthier environment. And because of this, our vaginal microbiome also gets influenced, because they live so close to each other. Not that there would be any transmission. Right. It's not that anything is going from back to front or front to back, but it does influence the bacteria. And when we have more probiotic rich foods, when we have more fiber, all of that influences how healthy your pelvic floor is.
Right. And it is so interesting. What about protein intake? Because again, we're talking about muscles, and does that impact it in any way?
It does impact it. It totally impacts it, because it helps in maintaining muscle tone, protein recovery. When we talk about the ability of the muscle to contract and relax, all of these muscles rely on the hormone. These are hormonally rich muscles, which have those receptors, which are very estrogen receptive. With regards to the mucosa, that responds to estrogen. And when we think about what the muscle base does, if we have adequate protein intake, when we have good fiber, protein, micronutrients like zinc, magnesium, all of those add to the quality of your muscle contraction. Then the sodium-potassium exchange, when a muscle contracts, when it relaxes, that influences it. So overall, it's a healthier mechanism. If we start pinpointing and saying that, oh, if I only increase protein, my muscle is going to be better, probably not. again, because all systems talk to each other. So rather than zoning in and only thinking about one food category, it's important to keep that balanced rainbow plate and then go on with it.
Yes, so balance is key, consistency is key. Let's say when one goes to a pelvic physiotherapist. So we have the scenario where one doesn't have access, and I want to come back to that in a bit, because I think a lot of us don't have access to a pelvic physiotherapist. Or there is so much that one can actually do at home. Like you said, drink enough water, like do all of that. So let's just come back to that in a bit. But if one does have access to a pelvic physiotherapist, what should they expect during a visit?
Yes, and this is such an important piece, because when we think about pelvic physiotherapy, a lot of patients who come in for the first time, they somehow ignore the pelvic part of it and physiotherapy, because it's a known word. So the impression is, oh, this is going to be like a physiotherapy session. I'm going to learn some exercises. I'll probably do some stretches and off I go. It feels good, which is true. Yes, there is an exercise component. But it is very similar to an interaction that one would have with probably a combination of three health professionals. I would say there is a physiotherapist in the room. Yes, there is also a medical practitioner, probably a nurse practitioner, family doctor, kind of a person who understands that aspect of it. And there would be an internal exam similar to what you would experience in a gynecologist office. Because that internal exam is the crux that would give us wealth of knowledge on what happens. So when someone walks into a room, majority of the part in the first initial assessment would be question and answer. Questions about their habits, their use of bathroom, their medical history, surgical history, if that's relevant. Sometimes we go all the way back to childhood history, because a lot of these habits are bladder bowel habits. They link to childhood and how we adapt those habits subconsciously, unknowingly, and these practices then later translate onto our adult life. So we kind of we peel the layers back and go, okay, let's start from the beginning. Where did you learn to do this? And then let's move ourselves up. So there's a lot of Q&A happening, a detailed question answer session. Then there is a medical history, because we need to know what would be the interaction of one medication with another. Sometimes there's medications which influence whether or not someone has constipation. There's medications which influence whether you go to the bathroom frequently. Blood pressure medication is a common one when people are on diuretics or high blood pressure cholesterol medication. Their bladder habits are different than someone who's not taking those. So keeping that in mind, it can't be a blanket statement. It's not a one size fits all. So asking those questions, understanding those dynamics, and then based on that, we get an idea about what is a clinical picture that we would expect. When I finish the question answer, then I go on to a clinical exam, which then gives me an idea of, oh, is this my guess? What are my best guesses? And the physical exam either confirms it or questions it. So that's what a session would look like. And after that, we come up with a treatment plan. We come up with a timeline of what is realistic. What should we expect? Can 100% recovery be achieved? And if yes, in approximately what time? There's no guarantee that, oh yeah, in 3 sessions, we're going to give you this, in 5 sessions. That if someone says that, then that's a red flag. We shouldn't be falling prey to that. But a realistic timeline of what would be expected in this amount of time, and what are the pros and cons, what are the things that they can do at home versus what kind of steps they should be taking in session, and how do we monitor it?
Right. And I think that from whatever you're describing, like going back to old habits and current habits, there can be so much of unlearning.
Yes.
And these are such, it's like this, like if someone says work on your bicep, I can see the muscle, I can, I know when it's moving.
Yes.
It's so hard to visualize, conceptualize the movement of the pelvic floor, just because what's not seen, sometimes you just find it hard to monitor.
Yeah.
So yeah, that's the whole challenge. I feel in my head, the biggest challenge is, they say no, jo dikta hai, wo bikta hai. What is seen sells. So
Right?
it's like
Yeah,
whatever is not seen, we tend to just kind of let it be. Just
for
doesn't
sure.
matter. So yeah, yeah,
Exactly.
yeah. But what about sexual health? The pelvic floor, how can it impact a woman's sexual health, especially at menopause? Now, perimenopause, menopause, of course, you're looking at vaginal dryness, you're looking at change in libido. But let's say we correct everything. Let's say we correct the factor of vaginal dryness with low dose vaginal estrogen, and there is enough hydration. So the vaginal epithelium is nice and healthy, the urethral epithelium is nice and healthy. Now we're looking at someone who's still experiencing pain or
Yes.
discomfort, or what else can happen, and how does it impact it?
Absolutely, absolutely. So there's three things that commonly happen when somebody has sexual discomfort or pain, not just pain, just discomfort with intercourse. Because it may or may not be pain. There's many layers to that. And the reason why we say why I use the word discomfort is because that discomfort could mean so many different things for so many individuals. I'll give you an example. One version is when the vaginal tissue is happy, when the mucosa is healthy, and you're still experiencing pain, then we are looking at what else is driving that pain. Because a lot of it is a learned response, what we talk about centralization of pain. Because there has been a previous incident, or there have been a few previous incidents when this individual experienced pain or burning or scratchiness or discomfort. And now every time they think about sex, there is that association of, when is it going to hurt? Is it going to hurt now? So that apprehension of pain causes that cycle of the muscles being really tight. Then the pelvic floor guards involuntarily, almost like a secondary vaginismus, where the muscles are tightening, and it doesn't cause for comfortable penetration, which is then a physical reason for pain. But that was not the main reason why the pain came. The pain came much before that. The pain was anticipatory. It came in your mind before the act actually happened. And now because of that, the muscles clenched up, and that's when penetration feels uncomfortable, and now there is a physical reason for pain. So it's like a vicious cycle. This is where we take a lot of assistance, a lot of help from co-referring and working alongside professionals. I very, very, very closely work with sexual health therapists. They employ cognitive behavioral therapy. I use CBT techniques in my practice from a pelvic health perspective, because there are some things I can do within my scope. There are other things which I don't know much about. So working alongside with them, talking about pain education, pain management, understanding, is the pain centralized? Is it legit? Because pain can happen when physically there is no problem with the tissue, but the pain is not imaginary. Nobody is making this up in their head.
Real.
That pain is a real.
Yeah.
It is a real experience. So that could be one reason. The second reason for discomfort could be physically the vaginal walls, the vagina is feeling fuller when they have the beginning of a prolapse, or when they have a milder prolapse, which is not functionally impeding anything. They don't have a drag, they don't have discomfort, or they don't have anything bulging out of their vagina, but they do feel fullness. And because of that fullness, it just doesn't feel right. Those sensors, the superficial tissue sensors, they are not transmitting the right amount of tone back to the brain, so that arousal signal doesn't come. First of all, there is lack of libido. Then there might be a difference between your libido and your arousal. Just because there's libido doesn't mean you would reach arousal. So it's a complex structure in that sense, where you think about these things. So that could be another reason for discomfort. And the third reason for discomfort is a lot of issues with self-image. When women go through perimenopause, menopause, they undergo a huge shift in their body image, body awareness, their self-image, because there is a very common mid-rise weight gain, which happens around the abdomen, around the belly, lower abdomen. There's a pooch that comes on, which makes them really self-conscious. And that would contribute towards whether or not you feel good. whether or not you would want to indulge in intercourse. And then you have this subliminal psychological thought of, does my partner perceive me that way? Does it actually feel good? And that dwells more into the psychological realm of things. But all of these influence whether or not your pelvic muscles are going to contract and relax. And if they don't contract and relax with your messaging, with your cueing, then the blood circulation is not adequate. The nerves don't send the right signals to your brain. If your brain doesn't get the right signals, it's not going to fire the right neurons. Hence, there wouldn't be the same level of arousal. And that's where there is that mismatch of your drive, where you feel like, I'm taking testosterone, I'm taking all of the estrogen, but yet I don't enjoy sex. I'm having intercourse. There is penetration. There's no discomfort. There's lubrication. But again, this doesn't feel right. So that feel right sensation happens when everything is in harmony.
Wow. I guess sex, libido, they're so complex, and there's so many factors that determine it. And to identify one more set of factors is good to know, and hopefully good to know, because then you can do something about it.
Yes.
So that was extremely useful. Now, coming back to the woman who doesn't have access to a pelvic physiotherapist. Now, if you could tell us, okay, we went through Kegels, and Kegels is questionable, its usefulness.
Yeah.
But give me 5 things that I can start doing at home today to keep my pelvic floor healthy for, healthy aging or whatever that let's say I'm completely asymptomatic, but I want to maintain a healthy pelvic floor, or I don't even know that I have these symptoms or what's going on. But basically 5 things that any woman can sit at home and do to help her pelvic floor.
For sure. The first and foremost thing is to see if you can drop down into a squat. When you go down and sit down in a squat, bend your hips, bend your knees, keep your feet flat on the floor. And if you can sit down in a squat without falling, without losing your balance, that tells you that your pelvic floor is stretching beautifully. Your hip muscles, your gluteal muscles, they are stretching beautifully. So that flexibility is there. If you had to test, if I had to give you one test and say, for someone who doesn't have access to an internal exam, how do I know? Do they have good flexibility in their pelvic floor? This might not be the ultimate test, because again, you could still drop into a squat and still have a tighter pelvic floor. But overall, if we look at it in a 70-30% sense, 70% individuals who can drop down into a squat and be there comfortably for 10 seconds would have enough flexibility in their pelvic floor where they wouldn't have symptoms. That's one thing that you can do. Start practicing squatting. The second thing that you can do to keep your pelvic floor really optimal is checking to see if you can contract the pelvic floor. So sort of like a Kegel, where you're squeezing and drawing away from your chair. If you're sitting in a chair, you can focus your attention on those pelvic floor muscles. When you squeeze, when you contract those muscles, you should have the perception that you're pulling away from the seat of the chair. So something is lifting up. And when you let go, it should feel like your muscles are dropping, almost like an umbrella opening and closing. So if you're able to squeeze and pull up or close your umbrella, and you're able to release and drop down, so open your umbrella, then you know that your pelvic floor is more or less flexible. That's another indicator. If you can recognize both of these movements.
Wow, I'm visualizing the umbrella. I'm actually like, this is quite useful.
Right?
Yeah.
The third thing that you can do is drink as close to 3 liters of water. If you can drink anywhere between 2.5 to 3 liters of water, that is fabulous. That's not just great for your pelvic floor, overall in your body. Everyone knows drinking more water is better, but when you meet that 3-liter water limit, it's magic. It works like a really, really magical way. The fourth thing that you can do is every night before you go to bed, lie flat on your back, keep your hands around your rib cage. So your hands are holding your rib cage on the sides very gently, very lightly. Yeah, exactly like that. And inhale and take a deep breath as if you're letting your belly expand. If your belly caves in, if your belly button sucks in when you take an inhale, you're doing the inhale wrong.
Oh.
Practice expanding your rib cage. It should feel like a 360 expansion. So inhale with your rib cage expanding and then breathe out through your mouth. So that inhale, exhale exercise is number 4. Fifth and most important is whenever there is effort, it could be effort for exercising, when you're lifting a heavy weight, or you're pushing furniture, you're moving something, or you're trying to have a bowel movement, when you're passing stool, when you're putting effort to pass stool. Anytime there is effort, leave your lips open, leave your mouth open. Don't keep your mouth closed and bear down. It shouldn't be, that effort with the mouth closed shouldn't happen. Leave your mouth open with effort, any effort. It could be weights, it could be exercise, pushing something, lifting anything. Just leave your mouth open with effort.
I'm going to have to observe what I do next time I lift weights. I just can't visualize what I do, but I'm going to pay. This is really useful. Yeah. So what happens if I do the, it's like passing hard stool?
Yes, that is the piston effect. So that is when your body starts to behave like pressure-filled can, and the pressure goes too much. Then that pressure doesn't have a place to regulate. Then that pressure doesn't have an escape. So you exert the same amount of pressure. You're not compromising on how much pressure you're applying. You're just making the can not behave like a piston. You're giving a valve. Your mouth behaves like a safety valve where you can exhale as you're adding that pressure. If I'm lifting weights up and down with that effort, if I leave my mouth open, I can do up and down rather than having that pressure closed and doing that. Wow. This is some of the advice that we also do when I have a birth prep session. I do a lot of prenatal training where we're teaching what is the right way to push. How do you give birth naturally without without affecting the pelvic floor too much. So that's something that we teach. Don't behave like a pressure can.
Understood. And that brings me to this interesting, usually there is a preconceived notion that basically women who have a normal or let's say a vaginal delivery are more prone to pelvic floor dysfunction. That is one part. But the second part is, are women who have a C-section spared from it?
No, they are not.
Yes.
They are not. That is not true at all. In fact, whether or not you would have pelvic floor dysfunction has very little to do with the mode of delivery, because delivery is just one event. Those are few hours when the pelvic floor stretches or compresses if you're giving birth vaginally. But what really affects it is the 9 months of weight bearing. For the 9 months, the weight that it has to carry, that is what affects how your pelvic floor behaves postpartum. So just because you had a C-section doesn't mean you're spared. In fact, I would say the opposite. Because in a C-section, you've already weight borne the weight of the uterus, the weight of the growing baby for 9 months. So your muscles would have had that stretching, that lengthening. And when a C-section happens, the mode of delivery is by stretching the abdominal walls, by making an incision through the abdominal wall. So your pressure can has the weakness from the bottom, and it also has a weak point in the body where the can is. So you have that incision, you have to heal it. You have to have your abdominal muscles come back after that stretching so it can operate more efficiently. So if I were to give an advice, I would say if you had a C-section, that is all the more of a reason to see a pelvic floor physio.
Right. So basically, just because you've had a C-section does not mean you are spared from any pelvic floor dysfunction. Everyone, men, women, everyone needs to look after the pelvic floor, women more. But C-section, delivery, doesn't matter. You just have to take care of it.
You have
that is the message to go with. Is there anything that you would like to add that I have not asked you today?
I think you've covered everything. You've covered such a good, expansive array of topics. But if I could add one thing, I think my big takeaway or my big advice to everyone who's listening would be ask about your symptoms. Don't ignore your symptoms, because when we interact with pelvic floor symptoms, a lot of it is shrouded in taboo, a lot of it is shrouded in secrecy. People are very secretive about discussing these things. It's not a coffee table discussion. It's not a discussion that one would have comfortably with their friends, or certainly not a commonplace discussion. So talking about how your muscles are feeling, talking about how your bladder is feeling, if you have trouble, if you notice that you're going to the bathroom more often, if you notice you're having trouble with anything in the bathroom, it could be pee, it could be pooping, it could be periods, it could be sex, anything in the pelvic area, if it doesn't feel right, I think it's important that women now start paying attention and voice it out, because there is treatment available. Most of these things, they can be remediated and they can be reversed 100% if they're caught within time. So rather than suffering in silence and just saying, okay, this is womanhood, this is the cost of being a woman, I think be an empowered woman, take accountability for it, and just ask for better answers, ask for a solution.
Right. No, and I think that that's so important. Asking, you don't ask, you don't receive. But
Right.
the other problem is also sometimes when we are asked, like, I feel like, I'm a provider and I'm only now more informed about the pelvic floor. 10 years ago, someone came to me with the same problem.
Right.
I think ignorance exists, and it's just because now I'm interested in this bit. I'm going down that road. But the point is, it's my need as a menopausal woman that's making me do this, and hence share it with other people. But most providers are not informed about when to refer to a physiotherapist. So I think that's the other part to address, is we can take care of, because very often, as you said, the woman is not going to a doctor, a physician, to a pelvic floor physiotherapist directly saying, hey, I have these symptoms.
Right.
The woman is going to her GP, her gynecologist, her urologist. She's going to these people for help. And if these people are then, say, hey, listen, you need a pelvic physiotherapist. Right? So I think education of providers can make such a huge difference. What do you have to say about that?
Absolutely. That is, and you're right, that is the number one way of increasing that awareness, increasing education, awareness of what can be remediated. Even when we think about pelvic floor or pelvic health as a niche, as a subject where now we have courses, now we have people who can specialize in this field. That wasn't the case 20 years ago. When I graduated, that was not, I didn't know that this could be a specialty that I could pursue. So getting that awareness is important. And making our colleagues, making our fellow practitioners aware about it, having discussions like these, sharing that information, of course. And these days, thankfully, social media is very rampant, and I want to take full advantage of it, because when you start to listen to these narratives, when you start to listen to the words, even the word menopause, for example, that is now being normal, that is normalized in conversation. 10 years ago, speaking about menopause wasn't something which was very common. Similarly, these things will slowly start changing, but it has to begin with us as a medical community, informing ourselves, educating ourselves, being more aware, so we can provide better patient care. Right. And from the patient's perspective, seeking for that information. Now we have access to information. Everyone has access to social media. Most people have access to the right kind of Google search. So that's why I say the right. Exactly. Right? So asking the right questions and saying, hey, does this symptom have an answer, or what could this be?
Yeah. No, I think that's brilliant. That's brilliant. This has been wonderful. What was meant to be a 30-minute chat has become an hour, but it's so interesting. I can keep listening to what you have to say and keep asking you more questions. But I think this is maybe we'll have another session on some more aspects or some rabbit hole into specific symptoms and complaints some other day.
Absolutely.
But thank you so much for sharing all of this. There is so much of information that is useful. I'm going to start using a lot of it, and I'm sure a lot of women will start using it as well. So thank you. Thank you very much.
Thank you. Thank you, Supreet. I'm glad. Thank you for having me.
Bye. Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.